Good afternoon, everyone. My name is Nadia Islam, and I am a professor at NYU Grossman School of Medicine. I think we're going to go ahead and get started with our very exciting program today, although we realize others may be joining us shortly. On behalf of myself and my colleagues at the National Center for Engagement in Diabetes Equity Research, or CEDER, we are really thrilled to welcome you to the first in our series of learning exchanges. Today's learning exchange will explore leveraging community representation and tracking representativeness to increase health equity and community engaged research. Recommendations from our colleagues at CAIANDTR, and they will share the full name of that acronym in their presentations. So these learning exchanges are, as the name implies, opportunities where we hope to learn from each other. At CEDER, we're committed to advancing research on type 2 diabetes that has impact across diverse communities. And we believe the best way to do that is to partner with communities through every stage of the research process. This learning exchange series came about through really a central tenet of community engagement, which is listening to communities. And listening to our partners at CEDER, they emphasize that sharing information on positive experiences with partnerships is really critical to advancing best practices in this field. And to this end, this learning exchange is designed to do exactly that. So this is our agenda for today. I'm really pleased to be joined by my colleagues, Dr. Nita Van Gipuram, and our very esteemed speakers, Dr. Amy Hubschman, Dr. Spiro Manson, Marcia O'Leary, and Dr. Sarah Soltz, who will be leading today's learning exchange. This will be followed by some interactive breakout activities and opportunities for us to learn from and hear from each other. And then we'll close out around 2:30. So I'd like to start by giving a brief overview of CEDER. I am one of the principal investigators of CEDER, along with my colleagues, Dr. Earl Chambers and Dr. Earlene Brown at Einstein School of Medicine and UCLA School of Medicine. But importantly, you can go to the next slide, please. CEDER represents a partnership between 18 academic institutions and 10 regional and national community-based organizations. And our leadership includes representation from community-based organizations as well. So our goal of CEDER is to provide resources and technical assistance to advance health equity and community engagement in diabetes-related research and programs. We have a vision of fostering community-led and community-informed diabetes research by really integrating community engagement across the research spectrum with a specific focus on type 2 diabetes and its related risk factors. We take our commitment to this work very seriously, particularly in the face of a changing federal context, as we're all aware, and strongly believe that it's only by partnering with communities who are disproportionately impacted by diabetes that we can achieve better health for all. To do this, we're really fortunate to leverage the expertise of an extremely extensive network, what we call our partnership hub, that includes representation from diverse communities across the country, communities as well as sectors. This includes schools of medicine and public health that you can see listed here, a number of community-based partners serving African American, Latinx, Asian American, Native Hawaiian, Pacific Islander, and American Indian and Alaska Native communities. And through these partnerships, we're also connected to a number of networks that have a similar vision of supporting community engaged and community partnered research. And you can see those listed here. Next slide, please. This is just a graphical representation of our partners across the country. And we are really proud of our representation across several areas of the country, and you can see that represented here. Next slide, please. So what exactly does CEDER do? I think I find it best to think about CEDER as really as a service organization. We provide services that include consultations and studios. And those consultations and studios are designed to offer advice to both researchers as well as community partners on how to better partner in research, particularly in diabetes-related research. So consultations are straightforward requests where one or more experts provide feedback, advice, mentorship, or training on specific diabetes-related research, evaluation, or diabetes programs. This can include sharing resources, providing reviews of grant proposals, providing advice and expertise on institutional review board issues, or simply connecting clients to other experts in the field. Consultations are typically brief and time limited and can be conducted virtually, via email, or other types of meetings. We also offer what we call studios, and studios are a chance to receive feedback and advice from a panel of experts on questions related to specific diabetes-related research studies or programs. This can include recommendations about a project or study design, strategies for how to maximize implementation, review of program or project materials for cultural appropriateness or translation, and or dissemination of study findings and thinking about how to do that in ways to enhance policy impact and program impact. Studios are conducted with a group of experts, and they're typically more time intensive and may involve more than one session. We launched CEDER services in the fall of 2024 and have been really pleased with our progress in engaging our extensive network of experts and working with clients across the country representing investigators from universities, health providers from federally qualified health centers, leaders of community-based organizations, bringing our services to them to better be able to partner in diabetes-related equity research. Next slide, please. So these are just some examples of how we can help to support you. I know we have a diverse audience representing both researchers, community-based organizations, and many other sectors. So suppose you are a researcher, you're wondering, how could CEDER help me? Some examples of a consultation we might provide are engaging with an expert to discover how to integrate health equity frameworks into your diabetes grant applications, ensuring a stronger proposal that addresses the needs of all communities. An example of a studio that we might provide is you could have the opportunity to collaborate with a panel of experts as they share strategies for effectively engaging community-based partners, for example, schools or clinics in your study. Next slide. But as I mentioned, our vision for CEDER is to really drive community-led research. We don't believe that only researchers can benefit from the services that CEDER are providing, but we really hope to engage community-based organizations, recognizing that community-based organizations generate a lot of practice-based evidence, and they play a really important role in contributing to our understanding of evidence-based strategies in addressing diabetes. So some of the ways, if you're a community-based organization, that CEDER might be able to help you. We know that communities collect lots of data. You do needs assessments, you're evaluating client services, you're conducting focus groups. And so CEDER can work with you on something like that, for example, to unlock the full potential of your community needs assessment by consulting with an expert to master data analysis techniques, help you generate insights and drive meaningful change through the data that you've collected. An example of a studio that might be appropriate for community-based partners is to be part of a panel that will equip you with essential strategies to effectively evaluate programs that you may be delivering in the community. For example, many CBOs are at the front line of delivering diabetes prevention programs. Evaluating those programs and your success are really critical to making sure that we can further disseminate programs and services like these to diverse communities across the country. Next slide. So this is my last slide, and then I'm really excited to turn it over to our speakers and our full program. Please do come to us. We've provided the link to our website, which is really the point of entree into working with us through CEDER. please do explore the website. There's a QR code here. The first step is to really go to our website and complete a fairly simple online form. That form will allow us to understand what your needs are, and how you would like to work with us. After that, we set up an introductory meeting with you and our sort of administrative core team. And then we connect you to subject matter experts. As you saw from that map, we have a vast network. We're connected to experts across a variety of communities and a variety of topical areas related to diabetes, diabetes prevention, diabetes management, really understanding the social drivers of diabetes. And so that in filling out the intake form, we can use that information to connect you to subject matter experts. So my last plea will be, again, to please visit our website, complete an intake form, and then we really hope you find today's learning exchange useful and let others know about CEDER and our services and our programs. This is the first of a series of learning exchanges. We hope to hold these quarterly, and we look forward to seeing you at future events. With that, I am going to turn it over to my colleague, Dr. Nita Vengupuram.
Thanks, Nadia. So welcome to our very first CEDER Learning Exchange. I'm going to be facilitating this session, and we'll start with the overall goals for the series. On the next slide. Thank you. So the goals of the CEDER Learning Exchange series are to share examples and best practices of positive research, community partnerships that highlight health equity and community engagement in type 2 diabetes research and programs, and to increase our understanding and expertise around policy, communications, grant writing, community-based participatory research, and other topics amongst Partnership Hub members and clients. So it's really anybody who's interested in type 2 diabetes health equity research, and we will be conducting cases with interactive sessions to really apply the things that we're learning about. Next slide, please. So I'm very excited to introduce a wonderful panel who will be speaking to us today. The title of their presentation for this learning exchange is Leveraging Community Representation and Tracking Representativeness to Increase Health Equity in Community Engaged Research. So I'll briefly just introduce our speakers. First, we have Dr. Amy Hipschman, who is a primary care physician and tenured professor at the University of Colorado School of Medicine in the Division of General Internal Medicine, and is also the director of the National Resource Corps for the Center for American Indian and Alaska Native Diabetes Translation Research. Dr. Hipschman's research focuses on advancing the dissemination and implementation science methods available to translate evidence-based interventions into real-world practice settings with attention to health equity concerns, and currently serves as MPI and lead investigator for one of only 7 NHLBI-funded UG3, UH3 dissemination trials to improve cardiopulmonary disparities. Next, we have Dr. Spiro Manson, who is a distinguished professor of public health and psychiatry, directs the Centers for American Indian and Alaska Native Health, and occupies the Colorado Trust Chair in American Indian Health at the University of Colorado Denver Medical Center. Dr. Manson is also a CEDER Partnership Hub member. His programs include 10 national centers, which pursue research, program development, and training, and 225 Native communities. Dr. Manson has served on the national advisory councils of 3 NIH institutes, the advisory committee to the NIH director, and is a member of the advisory committee to the CDC director. We also have Marcia O'Leary, who's the manager and CEO for Missouri Breaks Industries Research Incorporated, a small Native-owned research group located on the Cheyenne River Reservation in South Dakota. Missouri Breaks has conducted research throughout North and South Dakota, as well as many other Western states. As the manager and CEO of the organization, Ms. O'Leary has helped to develop more than 100 projects specific to improving health in American Indian communities. And finally, we have Sarah Stutz, who's an assistant professor at Colorado State University. Her research focuses on addressing food insecurity as it impacts adults with nutrition-related chronic disease, with emphasis on health disparities, nutrition education, social determinants of health, and multi-level approaches to chronic disease management and prevention. Her work focuses largely on serving American Indian and Alaska Native communities. We can go to the next slide. So just some learning objectives for today's CEDER Learning Exchange. We hope that by the end of the webinar, participants will be able to describe what our speakers will be presenting, the translational science benefits model, to describe gaps and provide recommendations for how to improve this model as an evaluation tool to measure impact with attention to health equity and community engaged type 2 diabetes research, such as including greater community representation and input into the research, and evaluating how well the outcomes and benefits are equitably distributed across different demographics. Also to identify gaps and opportunities for improving community representation and representativeness in their own work, and to identify actionable steps to increase community representation and representativeness in community engaged research. And with no further ado, we will have our first speaker.
Okay, hello everyone. Can you hear me? Everything okay? Nita, you can hear me?
Yes.
Yes, perfect. Well, I'd like people to put into the chat, you've been listening a lot, but this is about interaction and exchange representation. So put into the chat, if you would, who are partners that are represented, that you involve and have represented in research that you do, or who, if you're an organization with community representation, the types of communities that work with you. I'd love to see that in the chat from different people that we can react to over time. So I'm going to go ahead and get started walking through these slides for you as well. The title of this talk was already described. As Nadia noted, our abbreviation or acronym CAIANDTR is a little bit of a mouthful, but does stand for the Center for American Indian and Alaska Native Diabetes Translation Research. And the graphic that you have here will come to is really some of the products of our exercise we did working with our satellite centers who are part of our center that I'm going to talk more with you about. So I'll help to unpack it for you as we go through, but it's really supposed to be a living illustration of how we like to see representation in the research that we do. And Dr. Manson, I will have offer commentary as we go through these slides. I'll give him some opportunities to add comments. Next slide. So the work we're describing today was just published in late 2024, in December, in the Journal of Clinical and Translational Science. It was a special issue about the Translational Science Benefits Model, or TSBM. So for those of you who haven't heard of TSBM, I'll be talking through that today, but it was really asking people, hey, tell us what you think could be better about the Translational Science Benefits Model and how it measures impact. And we were excited to do that with the co-authors listed here on this slide, including their tribal affiliations for many of the authors in parentheses. Next slide. So we want to talk a little bit about who the people are who wrote this article together. There's our leadership of the CAINDTR, so our center co-director, Dr. Manson, and Dr. Angela Brega. You already heard about Dr. Manson, but they have key leadership roles for the center. Dr. Meredith Ford is our Community Outreach and Engagement Core Director and was the senior author for this article. Dr. Sarah Stutz, who you'll hear from shortly, is our Enrichment Program Director, who really works on having learning exchanges like this as part of our center that are fostered across our partners in our networks. And then I'm the National Resource Core Director for our center. This is one of several centers for diabetes translation research funded nationally, and each center has these different types of cores to constitute it. Next slide. Things that are different about our center is that we have these satellite centers of with American Indian, Alaska Native leaders from academic centers around the country. And so there's leaders from Alaska, Central Plains, Pacific Northwest, Southwest, Southeast, and the Rocky Mountain region, as you see going around the slide. And so these are the folks, they and their staff, who came together with us in this exercise to think about how to make the translational science benefits model better. So we really had a lot of representation for this work, is what I'm trying to get across. Next slide. The learning objectives were already given to you for the CEDER as a whole, and these are objectives what we're trying to get across today. We want to get into the why, unpack why we did this this work, the premise. Then we'll get into our methods, talk about how we did it. We'll talk about what is representation and what is representativeness, and why being concrete about those constructs, why does that matter for better science? We'll summarize results and key takeaways, and then have the open discussion, which I'm really looking forward to. And I'm not seeing much in the chat yet, but if you are able, please do put in to the chat information about who is represented in your work, what are the community representatives. Next slide. And thank you, Jeanette, for starting that off. We'll welcome others to put in as well, partners that you work with. So a word, Nadia said at the beginning, that there's been a lot of changes with the recent federal transition, a lot of concern about certain terms and language and what are guardrails for what we can say and can't say. So I want to just give a clear perspective on what we mean when we say the term health equity. Our focus is on advancing the science, and we want to develop research methods that will improve the health impact of research programs for all people, for all groups. To encapsulate that focus, in our article that we published, we used the concept of a health equity lens, and you'll see that picture and graphic. We know that equity as a term has come under fire since this work was initially published. And what I want to be clear on is the thrust of this work is to overcome health disparities, to improve health for all people, for all groups. And this conflict of interest statement clarifies that this perspective is ours as the authors and not that of NIH. Next slide. So the why we did this work. The translational science benefits model, if you haven't worked with it yet in your sphere of influence, it's really come into quite a heyday in the last 5 years after Doug, Luke, and colleagues initially published it. Doug and colleagues said, we need to make sure when we do research that we know that it impacts people lives. It impacts things that matter beyond having manuscripts, publications, and then future grants. And so they really pushed us to say, in the categories of clinical benefits, community benefits, economic benefits, policy benefits, what happened from this work? And their website that they've developed allows you to do case vignettes and things of that nature. Many NIH-funded initiatives, including our CDTRs, are required to report our impact now according to the translational science benefits model. I think this is a good thing. We want to say, what are we doing that really is changing, moving the needle in these areas? But there's been limited guidance on how the TSBM areas of impact relate to health equity, improving health for all. And we saw this as an opportunity and a gap. What you can see on the slide for the translational science benefits model shown is what Luke and colleagues published, and it has along the very bottom contextual influences, all the context, including external environment, inner settings or of organizations. And then it's a logic model that moves left to right and says, well, you have some resources, then you do some scientific activities, and then you get some outputs or outcomes. And then that ultimately is going to land on the far right to translational science benefits. That's how Luke and colleagues developed this. Okay, next slide. So we already had some grounding to work on, some movement towards considering equity from the work by Julie Schmidt-Deal and colleagues in our Centers for Diabetes Translation Research. They had taken and worked with NIDDK colleagues and others in our centers to say, let's try to make this work for our Centers for Diabetes Translation Research, what Doug, Luke, and colleagues put together. So the areas that are red stars are things that they already had added and that we were looking at in addition to the overall framework or model. And those included having an equity lens for the context, understanding if there's certain groups that didn't have as much representation or voice, that type of thing. They also had looked at additional measures of impact, things like capacity building. Is there a way to help organizations do more than they could otherwise? And how we often are better together, looking at multi-sectoral collaborations and partnerships. I love that people are continuing to put in the chat the types of representation that you have in your work. So please keep that coming. Next slide. So what we set out to do then was to describe and critically evaluate the gaps in the fit of TSBM with attention to overcoming health disparities, promoting health for all. And we wanted to propose some amendments to the TSBM. What are things that could make it even better? And we're leveraging our colleagues' expertise across our regional satellite center network and also their community engaged research experience. Next slide. So our process was this community engaged critical approach, and the participants were those in our community of practice, our regional network of the satellite centers I showed you on the earlier slide. Next slide. So here's a map-wise depiction of where the satellite centers are, and it includes on here key staff leads of the centers, as well as the pictures I'd shown you earlier of the actual leaders. You can see we have nice regional representation around our country. Next slide. In terms of our methods, this was a type of a human-centered design approach. In addition to the critical appraisal, we presented the translational science benefits model, what it is, and also the CDTR impact framework that I just showed you, what it is, to our satellite centers. And we asked them to think about, how does this relate to the impact of your research? When you see a positive impact for your community, does it show up in these different areas in the logic models? And then we iteratively reviewed and revised the diagrams and the logic model based on input and brought it back to the centers and said, how about now? How is it looking now? And continued to iterate until people were comfortable and said, yes, this is really strong at this point. And we heard along the way that two key areas of refinements that were needed were to call out the importance of community representation across the continuum of research projects, from very beginning, glimmer in the eye of doing something, to evaluating it and sustaining it. And also to look at measuring representativeness, meaning who benefits? Are there people who are not benefiting while others are only standing to benefit when this project rolls out? That was important for us to talk through together and get real clear and granular on what it meant. And then we had follow-up outreach and brief calls with each co-author to make sure at the end that they were satisfied with how the final products. Next slide. So the two key goal deliverables we had was make a visual model of our Center for Diabetes Translation Research as one way to show how community representation was occurring for us and what we thought was a good light, a spotlight to lift up for what others could do to have representation in work that they were doing that would achieve impact. And then we also proposed enhancements to the original logic model of the translational science benefits model, including representativeness and representation, which I will show you. Next slide. So representation, these were the definitions we came up with, one for representation, one for representativeness. And community representation, we defined together as an indicator of providing community partners a seat at the table across the research lifecycle to generate solutions, innovations that influence equity, and to prioritize which outcomes to evaluate what will be success from their point of view. And then representativeness would be to assess who benefits for these specific measured outcomes. And is it just one group, one subgroup, or is it pretty equitable across demographics? Next slide. So this is the visual model again, and Dr. Manson, in a moment, I'm going to ask you to come off mic too and talk about this with me. So the thing that we really wanted to get across here, you saw the original translational science benefits model that I showed you. It was a linear model. It just started at one place at the beginning, it ended at the far right, and it was done. And what you'll see here is this is very circular, iterative, recursive, and we identified representation, as you can see, really as a forest ecosystem where our Center for American Indian Alaska Native Diabetes Translation Research and the co-leaders of that group are this central tree you see at the top, including things like our pilot feasibility program, having some baby trees growing up, and that our satellite centers that are dispersed around the country have really rich interconnections through the roots of the trees with our tree, with the other trees. And what we wanted to model by this is that we're sharing strengths, sharing innovations and things that work with one another so that they could be adapted and used. It's a strengths-based approach from each of these centers. And we also wanted to highlight the biodiversity of this ecosystem. We had different trees, like a birch tree in Alaska, cedar tree in the Pacific Northwest, pinyon tree in Southwest, to show these are native trees to their area. They work, they grow there. You can't necessarily grow the same tree everywhere. And that the trees give fruit and there's produce that's borne out in the areas. So we also showed kind of prized local produce in each of the areas in woven baskets to give clear reflection to the notion that there's benefits for these communities that that come out of sharing this health information and health programming with one another. Dr. Manson, do you want to offer any other comments about the model?
Of course. Thank you very much, Amy. Thank you very much, Amy. I think there are a couple of points to underscore here. First off is that one of the struggles I think most of us working in the academy and as scientists have is less communication among us and our peers and the challenges of communicating with our constituents, the nature of our work and the importance and relative value of a variety of features of the work that we undertake. And so this image, this metaphor, if you will, is particularly powerful in communicating the nature of our work to our community partners, urban, rural, and reservation-based American Indian Alaska Native communities. And it is quickly embraced by our constituents. It enables us to then introduce more discipline-specific kinds of constructs, such as the nature of sampling, the nature of representation in terms of ensuring adequate variation in the nature of our work to enable us to generalize to more broadly to other populations, but also to accommodate the rich variation that we know obtains at the local level. And this was I think, a real breakthrough for us in terms of arriving at a vehicle by which we could communicate those aspects of our work. And I'll leave it at there in terms of the value of this. And I think each of us struggles with communicating these concepts and the value added for our work with our community partners who don't necessarily operate in terms of the same vision that that those of us who come from a position of essentially scientific and a biomedical worldview. Thank you, Amy.
That's great. Thank you, Dr. Manson. And I'll go through a few more slides and then have you come comment further as we get towards the end here. So next slide. So this is the second deliverable of taking the logic model of the translational science benefits model and then overlaying on it what is different and what we wanted to recommend as amendments. So at the very top is sort of the high level, right? And it puts a magnifying glass to say this magnifying glass is a focus area of equity. And that overall, what you're going to see on this slide is a spectrum of ways to increase external validity. You're going to improve the representation of partners across all phases. That's going to help lead to more representativeness of outcomes, a greater chance that everyone can benefit by having more voices represented along the way. And that representativeness of outcomes is going to be key, who benefits and who does not. So the left-hand column of resources you know, I'm going to have us now kind of go back and forth, toggle between this slide and the next slide. So go to the next slide and I'll bring you backwards and reverse in a moment. So you see that what's different in the purple here, it's a little subtle, is that partners with lived experience is part of who we want to have involved as our community partners, thinking about what lived experience is particularly relevant and salient to the scientific question. Then if we go back a slide again, and we look at number 2 for knowledge resources, and we go forward one slide, then you see that it's making sure we have local context appreciated. And when Marcia gives her case study in a moment, it's particularly going to give some really key elements of local context that you need to make sure are you're getting good boots on the ground information from that. Then in terms of slide 3 for collaborations, if we go back one, so you can, yep, then forward one, you can see for collaborations, we made this whole spanning of yellow across the whole time to say, this can't just be happening at one phase that you're doing collaborations. It really needs to be power sharing, and you have collaborations across the life cycle of a research project. Under 4 for responsible conduct of research, it's respecting the data sovereignty of tribal nations. It's a key piece there, which I'll have Dr. Manson speak to in a moment. And then at number 5, those things that are the little like splashes, I showed you earlier the CDTR research impact framework. So it's just saying those were some things A and B that had come from there. But this is where we really called out, we want to assess measures that promote equity by calculating how much engagement is there. If we talk with the partners who are involved and we ask them to rate how engaged the team is with them and they're engaged in the project, do they rate it like lukewarm, like I'm not really that involved? Or do they say, yes, I'm like really right there with them? And I love that there's some great emerging survey tools to help us do that more easily. Also looking at community capacity and representativeness of outcomes. And then finally, as we move over towards the far right in 6 and 7, the items you can see in purple there are that you're sustaining community academic partnerships, sustaining these collaborations and partnerships, and also the impact on unmet social needs and fair compensation of partners. If there's any financial benefits gained from doing this project, that those would be shared equitably with partners. Dr. Manson, do you want to comment on any of the things here in particular? I thought data sovereignty of tribal nations might be something you'd want
Thank
to
you,
add
Amy.
to. Yeah.
Yeah, I want to go back to your earlier comments about the emphasis on improving and enhancing the science that drives our work in large part. And that is, of course, at the heart of what this effort is about. That representation and representativeness enhances the science. In what ways? It helps us understand and expand the nature of the theories that we believe underlie the kind of dynamics that we're talking about with respect to diabetes-related phenomena. It helps us think through more carefully the ways in which we design the studies that spring from those theories, all the way from what we're measuring, how we measure it, whom we measure, the key constructs among. I saw in the chat there are a number of people who are working with different populations. When we think about populations, we're not talking just about American Indians and Alaska Natives. We're talking about adolescents, older adults, rural, urban, etc., all really important sources of variation. And going back to this notion of external validity, the emphasis is on ensuring that there is the generalizability by anticipating and accommodating the variation along these lines. And Amy just mentioned this notion of data sovereignty. I think all of us, whether you're American Indian, Alaska Native, an older adult, a younger, an adolescent, you're deeply concerned about the nature of the knowledge you choose to share with others and what what is made of that knowledge, how it can not only benefit others, but you and your family and your peers. And we have a greater emphasis, I think, and responsibility to be more transparent and proactive in communicating to others the intent of the acquisition of this kind of data and the knowledge that follows from it, and ensuring that the way in which we govern our work through representation includes the voices of those who possess and share and have such great emphasis on the application of that knowledge.
Wonderful. Thank you so much. Next slide. So briefly, I'm just going to show then this was an example from one of our satellite centers. Dr. Stutz is going to go into more detail with a case example shortly, but the Southwest Satellite Center was examining the interrelatedness of diabetes and hypertension, diabetes and dementia, and looking at sharing worldviews of community and traditional healers as well as tribal health providers. So they did a participatory strategic planning approach to promote representation grounded in consensus building, and said they wanted to critically evaluate what's possible together across these groups and identify a set of priorities and a plan that would be realistic, achievable, would have promise keeping of what we say we're going to set out to do, we will be able to follow through. Next slide. And then the ways that they looked at representativeness and what happened by doing this work is they were able to find greater acceptance of disease management messages by the community when they received it from different perspectives, both the traditional healer and the Western science perspective. And there was a co-created tribal leader vetted policy that came from this, spurred from this, as well as further support of what could happen next, looking at options for things like in-home diabetes monitoring and technology that were becoming possible. Next slide. So the key takeaways I have is that our proposed enhancements to TSBM align with the overall goal to assess impact on health and societal benefits that matter. It helps to move the science, as Dr. Manson was emphasizing, and also adds further specificity to the equity lens innovations that the CDTR research impact framework proposed on top of the translational science benefits model, and are really in line with national recommendations to use implementation science and diabetes translation research to further health for all by having good representation and assessment of representativeness. Next slide. Our co-authors from the satellite centers were really positive about what we were able to pull together from this. So as they couldn't all be here together, I shared a couple of their comments here on this slide. Next slide. I want to acknowledge again our leadership, our satellite center leaders, and my colleagues who helped with developing this presentation. Next slide. These are the newest set of satellite center leaders. I showed the older slide, but this now has Dr. Cole Alec in the bottom left and Dr. Colette Adamson in the upper right, who have joined the team this year. Next slide. And I already showed you the slide earlier of our leadership, but again, acknowledging their role in taking this work forward. Next slide. So I'm about to pass it to Dr. Sarah Stutz here, but Dr. Manson, are there any other reflections you want to give? We could go back one more slide and see if Dr. Manson has any other comments before we pass the mic to Dr. Stutz.
Thank you, Amy. Just one, and that is, although we focused on the TSBM model, these kinds of conversations and efforts apply across the variety of different kinds of research models that are at play in this particular field. Notably, the REAIM and PRISM models that Dr. Russ Glasgow has developed. And in fact, Dr. Meredith Fort, who is the senior author on this particular article, Dr. Glasgow and I published a piece on looking at very similar kinds of aspects of the PRISM model and the benefits and the challenges and the benefits and the value added by paying attention to the very same concepts and principles that have been discussed here. So it really doesn't matter what particular model one is using to guide one's work and relationship with community, as long as these kinds of models are expected, in some cases required, to guide the work that is sponsored by the National Institutes on Health and other agencies who fund our work. It's imperative that we be critical consumers and users of these kinds of models in the fashion that's been discussed here, and you'll see illustrated very concretely in a moment.
Thank you so much, Dr. Manson. And so now I will pass the mic to Dr. Sarah Stutz to go through this case example. Take it away, Sarah.
Great, thank you. And let's see, Emma, can you hear me, or Claire, or anybody?
Yes, we can hear you.
Yes. Okay. Thanks, guys. Well, thank you for giving me a little time here. I won't take too long because I want to make sure that Marcia gets plenty of time and we have time for the discussion and the breakouts, which will be really exciting. So, Amy and Sparrow invited me to just talk a little bit about one of the case examples that's featured in the paper that they've been referring to, but there's certainly others. So if this case doesn't resonate or doesn't give you a concrete example, please refer to the paper because again, there's others. So I'm going to talk just a little bit about our team's work on the development and evaluation and implementation of a diabetes nutrition education curriculum that is specifically designed and tailored for American Indian Alaska Native adults who have type 2 diabetes. And you can go on to the next slide, please. Great, so thank you. And so this particular curriculum, one of the important parts of it that I always like to bring up is the inception story of it was that American Diabetes Association partnered with tribal communities because the Shakopee Mdewakanton Sioux community specifically had the idea that they wanted a nutrition diabetes specific curriculum to serve Native communities. And so the idea itself came from Native communities. American Diabetes Association partnered and helped creates funding and find some folks who could actually develop the curriculum. But again, the idea itself came from a need from community. One thing that is, I think, really exciting now with the curriculum, now that it's developed and has been undergoing different variations of evaluation testing, is that we're doing a pretty robust dissemination where we're meeting with any community, really, any Native serving community who wants to learn how to use the curriculum. We're doing some very 2-day train the trainer workshops. They're no charge for communities who want to be trained to teach the curriculum. It's not a requirement, but certainly if folks want to learn what was the vision of how to create that or how to lead this curriculum. And in that, we are learning from the folks who are out there teaching the curriculum, things that are working, things that are not working, areas that they'd like to see changed. And so our team right now is, with all of that feedback, providing some guidance to American Diabetes Association, who owns and endorses the curriculum, as to how we'd like to adapt it a little bit further to better meet the needs of the communities that have been utilizing it. The focus of the curriculum is specific to nutrition and diabetes education. So it's not doesn't talk about all the other aspects of diabetes care. So because of that, we're able to really have a nice focus on incorporation of traditional foods as available to folks. We have a lot of visual and arts-based learning activities and a lot of space in the curriculum for peer-to-peer support and kind of co-creation of knowledge through storytelling and experience and lived experience between the participants that engage in the classes. We're really proud the curriculum also has all original photography that is of Native folks doing the activities such as eating and physical activity and all of the things that are included in the curriculum. And just finally on the bottom box there, you can see one of the policy implications of our work that we're really proud of, and just grateful for the American Diabetes Association to continue offering the curriculum at no charge for American Indian Alaska Native serving communities. The little QR code that's there will take you right to the American Diabetes Association website where folks can request access. And that is just something that we've advocated really hard throughout the course of development and evaluation to ensure that because it was the idea of community, because community assisted and still continues to lead the way in adapting and making the curriculum what it is, that certainly offering it no charge back for community is the right thing to do. And ADA agrees. So that is my spiel on what can I eat. I will be here in the breakout rooms and so forth to answer questions, and just grateful that that we had the opportunity to share a little bit about some of the work that we're doing at the Center for Diabetes Translation Research here in Denver. And I think probably Marcia is next.
Thank you, Sarah. That was those are wonderful examples of community involvement and translational work. My name is Marcia O'Leary. I'm going to give you just a very quick overview of our organization. We're a small American Indian-owned research group located here on the reservations in the Dakotas. We were established in '95. We have approximately 50 staff members located across the Dakotas. We have done a number of research projects, everything from observational work to clinical trials, including some work with the Warp Speed clinical trial, the Novavax vaccine. We've done a wide variety of work. And I just thought I would bring you up to date on a couple of the case examples that we have worked on. So probably one of them is we were asked to assist with a project that was HPV project. It originated in the Southwest. Its original goal was to recruit approximately 2,300 or 2,500 participants. And in 3 years, they had weren't especially successful. They'd only recruited approximately 250 folks. And we were asked if we were interested in becoming involved in this project. And if we could, if we would be able to recruit about 500 people or 500 women. The idea behind this project was to test the kit. So the idea was to use a tool that was used in other populations in other parts of the world to see if you could test for HPV in a home setting and get actionable results. And so we said, sure, would be interested in talking to our tribal leadership and seeing if that was something that they would buy into, if it was something they would support. So we went to our local IRBs to see if there was any interest, and we got an emphatic yes, because of the concern of cancer is always the scary word, right? Although we know that that cardiovascular disease actually has a lot bigger impact. We ended up recruiting about 700 women in 6 months. I think that the implications from this particular project was that that people, yes, they want to, that all populations want good health, that they want to be able to participate, that they want to have their communities represented. The thing that was interesting, and I think that this is something that everybody learns over time, is that it wasn't just the fact that we learned a tremendous amount about folks wanting to participate and their willingness to participate, given the right direction and the right opportunities that are offered. But more than that, there's the unintentional results. And so one of the things that we did learn from this study is that that the most common HPV viruses, and that's what was tested for, was those that actually cause cancer, weren't represented in the common strains that are found and protected against by today's vaccines. Now, where the borders, we don't know that. So what we learned was that, we have some strains here that aren't common in other populations. There's a tremendous amount more to learn about this. But what we did identify was the fact that the Gardasil 9 doesn't cover the particular strain here. We don't know where the borders are. We don't know if those are Minneapolis, Denver, Salt Lake City. We don't know if it's a national problem that's just simply not being tested for. But we did, the unintentional results were really important, and that the important thing is that we need to do bilateral education to promote vaccine coverage, because even though it doesn't necessarily cover the strain that's most common here. People can have more than one strain. And so the vaccines do help. We just need to promote and learn from the information that science can bring us through our partnership. So it's really critically important for us to use collaborate with our, most people are looking at collaborating with, from your perspectives, probably collaborating with American Indians, or rural Americans. Our perspective is collaborating with the scientific and academic communities. So that's, we're all on the same page, just coming from different angles, or you might say the same path, just getting on it at different places. Another example of work that we've done is something called Mercury in the Water. It began through a partnership through the Cheyenne River Sioux Tribe, EPA, and we were looking specifically at high levels of arsenic in the Cheyenne River due to runoff from mining pilings from the Homestake gold mines, which have been closed for many, many years. And today, some of you may be familiar with the Sanford Labs, which now occupies that space. But there's a lot of pilings that still remain, and the runoff has gotten into the Cheyenne River Sioux Tribe and has exposed a lot of area to high levels of arsenic. And so through work with several different entities, University of New Mexico, Columbia University, we've done quite a bit of different work on exposure levels of mercury, arsenic, and different toxins in our water. And again, looking at the different pathways that people are exposed to arsenic, one of the things that we did learn was that people had a very high level of exposure to arsenic in their system. And so then the question was, what is that, how are the people getting it, and, what is it that can be done? One of the things that we always look for whenever we partner with any entity is, how does this information inform legislation? How is it actionable in our communities? Because as they say, all research is personal, its value is how it is meaningful to myself, my community, my family, at the end of the day. So this study, the Mercury in the Water study, I involved about 225 people. We were looking at people that were specifically fisher, using, fishing for sustenance. And one of the things that we originally identified was that 89% of the participants had high levels of cotinine in their system. And so we used some of the data that came from this work, as well as a couple of other pieces that we've worked on, and helped to, and it was used to help inform legislation on the Cheyenne River Sioux Tribe to reduce exposure of smoke in public places. So they passed what's called Ordinance 77 in 2014. And at that point, 89% of the participants reported workplace exposure, and they had very high levels of cotinine. So after this was reported, and that included children, right? So we were able to test cotinine in elders and children, and we knew that the children weren't smoking, but they were 89% of them as well. In another study was showing that they had very high levels of exposure. So, in a roundabout way, when looking at heavy metal exposure, we also tested for tobacco exposure, and the incidental findings were that these high levels of were discovered of these high levels of cotinine. As a result of the passage of the ordinance, a few years later, like in 2016, we were able to go back and test people, and they had their exposure to cotinine had dropped to like 25%. So it was really significant and had really meaningful results on the ground. The other thing that has come out of that particular data is that we have now what we call chinchasha retreats, because typically, or because of many factors, people were using tobacco for ceremonial purposes. And as a result of some of the data that came out of some of this work, we were able to start promoting chinchasha, which is red willow. And we now have take our youth out on chinchasha retreats to teach them how to process and harvest chinchasha and use it for ceremonial purposes. Another thing that came out of the data that we learned is one of the things that we really are very excited about is that a lot of the data that we gather is used to train young investigators. And one particular investigator that was working with Ana Navasasian out of Columbia University, very capable individual, was that she wrote an article on arsenic, and using a combination of data was identified that that there's very high exposures of arsenic in people that eat organ meats. And so she had determined from her analysis, which is, was interesting, that she felt like the people that were eating organ meats were actually folks that were, eating beef that drank water out of the Cheyenne River Reservation, or the Cheyenne River, located on the southern end of the Cheyenne River. Now you have to understand that the Cheyenne River Reservation is about 4,000 square miles. And so we can assure you that the cows were not walking to the Cheyenne River to drink. That's just, not possible. But because of the importance of the partnership of involving locals in the analysis, and that's true in all of these cases, we were able to make sure that information wasn't put out there that was totally incorrect, because once it's published, it's very hard to get it retrieved or back it out. So next slide. Okay, so lessons learned, and we can make this quick, is that, respect and, whoops, I think this is, yep, you have to go again, please. Okay, so that, that it's very possible to work in any population, whether it's a rural tribal nation, whether it's in a rural community. Again, all research is personal. And so there's a process to follow. So a person just needs to do that, find out what that process is. Every tribal nation has its own way of operating. Every urban area has its own way of operating. You just need to learn and ask, how do you do that? What's the processes here? How do I get involvement? I think it's really important to process or to promote multi-purpose data use. I think a lot of the things that we've learned has been because we've been able to draw from a lot of different entities and get data use agreements in place so that we can share information and results. Acknowledge that people have different expectations. So it's okay for scholars to need a publication for their work, but it's also okay for tribal communities to have expectations that there's going to be actionable results. And so it's really, really important for us to see that perspective. And as in all things, speak less and listen more, promote mutual benefits. So, and I think it's important that we understand that we're educating both ways. We're not just educating our rural communities, we're also educating our academic partners on what the expectations are and how to operate and what the data's meaning is. And distinguish the difference between speaking for and advocating for the communities. And that's true in any community. So I think it's really critically important to know from the get-go, you don't speak for the community, you listen to it and you advocate for them so that things can, so that you can build capacity and that you'll have a deeper bench and you'll also have folks to come back to, because any good research leads to more research. So when you have deepened that bench, then you have somebody to go back to that's trusted in that community. And that's the best way to do research in any community. Next. And that's it. Thanks.
So thanks so much to all of you for your presenting your amazing work. We were going to do some small group activities, but since we're running a little short on time, we will be just doing our Q&A section. I do want to call attention to one question that was in the chat. I have to scroll up. It was a question. All right, let me read it. Would you discuss the roles of bridging members of the team, this goes back to the model that was presented, people who are both representative of the impacted population and have scientific training and involvement? For instance, a Black kidney donor who is also a faculty member. And I know, Dr. Hirschman, you started addressing it in the chat, but I don't know if you wanted to comment further.
I'll start by verbally, kind of riffing off what I had in the chat and encourage Summer to let us know if this is covering your question or not. But, we definitely encouraged with our amendments to the translational science benefits model that we would have people with lived experience as part of the research team. So having a faculty member who's a Black kidney donor that is either part of the research team or part of the advisory board, consulting with the team, collaborating with the team, brings important different lived experiences that would at minimum allow the research team to be hearing at least a voice from someone with lived experience as the team is making deliberations, and potentially also offers more entree to get additional community partners with lived experience, others who are kidney donors or have kidney disease, to be part of advisory board. So that was what I had put in the chat. Welcome any other comments?
Well, I think that that's a necessary, but it's not a sufficient condition. I think with respect to the question, that kind of diversity adds to the perspectives and the ability to understand and anticipate variation in important ways, but also to these bridging individuals serve as translators. We in the biomedical world have particular ways of talking, logic, and language. And that is true if I shift into my role as a tribal member. And the opportunity that bridgers provide is the translation back and forth. And I think we facilitate the conversations in that nature. We also are in a position to advocate one position vis-a-vis another, or one perspective vis-a-vis another, in very informed and possibly strategic ways in the research process itself. So I think that there is that kind of functionality that bridgers serve, in addition to bringing diversity to and variation to these conversations.
Great, thank you so much for those responses. Marcia, you shared a lot of your amazing research projects, and I was just wondering if you could comment on any key lessons across the very diverse projects that you talked about that may be applicable to other communities across the country.
Sure. So I think all of these are applicable across the country. I mean, all of, like I said, you know, all research is personal. It's all parochial. It's all local in its meaning. So I think when we are immersed in the work that we do, that we find, you know, we see our path very clearly, and we don't always recognize that other people aren't on the same path. So making sure that we give grace to other folks and recognize that they come from different backgrounds and different circumstances is really important for us to include them and make sure that what we're doing is meaningful. You know, we believe that, you know, the purpose of research is to inform legislation, to improve best practices, to change standards of care, and to provide, you know, to drill down on change. So, you know, I think, you know, making that as meaningful as possible to our communities at whatever place they're coming from is really critically important. I think sometimes we think, oh, we know what people need, but we don't. We have to talk and listen to them and communicate. And we have to, just like I said, give grace to the people that we work with. I think that's critically important.
Thank you. Yeah, you brought up, I think, two really important points. One is that, you know, regardless of where you are and who you're working with, it is constantly having that dialogue to make sure that the work is meaningful and impactful. And the comment you made about research to action, whatever that looks like, whether it is changing standards of care, whether it is advocacy, and that communities really need to see the translation of our work into something concrete, and that knowing that they contributed to it, which is really empowering.
I think that's what the first question that we always get is, well, how is this going to help us? How is this? And I think that's a universal question.
Absolutely, regardless of, as we noticed in the chat, people, you know, sharing the populations, the communities that they work with, regardless of racial and ethnic background, regardless of gender background, regardless of age, regardless of geography. Everybody has a story to tell, and everybody wants to see positive impact come out of the research that they participate in. Thank you. Dr. Manson, I have a question for you about just with your perspective from CEDER and NIDDK, how can these large entities, funding agencies support researchers and community groups who are interested in increasing representation and evaluating representativeness in their community engaged research? And what other resources or trainings can we think about providing on a sort of global scale just to support these efforts?
Well, I think there are multiple answers to that question. Let me see if I can just select a few. One is being assertive and seeking out through a variety of means opportunities to have a seat at the table. I am reminded by my paternal grandmother, who died a week short of her 100th birthday. She said to me, you know, if you're not at the table, you're not going to get fed. And I think many of us also realize that it's also possible subsequently to be on the menu. And the opportunity to help shape the nature of the work sponsored by these agencies is critically important. You mentioned earlier some of the advisory groups that I've been privileged to be a part of. It is absolutely clear to me that that those groups benefit from a diversity of perspectives, but cast in their particular way, in their particular form, as what's the value added to the science. And we can answer that. We can answer how representation and representativeness, how community engaged work adds and is of benefit to the science. There are multiple ways. We have now literature that strongly supports the fact that more diverse teams in research and science are more productive, more creative, more innovative, that the discovery process moves forward more quickly, etc. All of those kinds of potential outcomes are of great interest and deemed valuable by the sponsors of this kind of work. So it is, I think of as well, developing relationships with many of the mid-level people in these agencies. We refer to them as program officials at NIH, but they have their counterparts in HRQ, CDC, et cetera, et cetera. We think of them as becoming our internal champions of you have a foothold that you establish by developing those kinds of relationships, the opportunity for exchange and shaping and identifying the ways in which one can influence the work of the other, and maximize the opportunity for contributing to the mutual overlap in our respective agendas. And there have been historically many, numerous training opportunities. And I think CEDER offers this notion of studios as an opportunity to dive down even more deeply into many of these aspects. I participated last week in a studio with a young colleague working in diabetes, particularly among adolescents. And it was a wonderful opportunity to share the lessons learned and to identify the way in which those lessons may have implications for the nature of that work, and how not only to shape the work and the science behind it, but also how to maximize the dissemination and application and thus value, as Marcia was just talking about, to the constituents.
Yeah, thank you for that. I think it's good for those of us who've been in these fields for a while now that there seems to be an increasing recognition of the importance and even an expectation that um, and written out, how research teams are trying to improve representation and representativeness in their work. And so um, it is not just to serve our communities better, but it is also to contribute to the science, as you said, and an expectation to get the kinds of funding support that we need to do this work. Thank you.
Nita, I'd like to add a note of optimism. I mean, it's very
Yeah.
easy to be deeply concerned and worried, and even in some cases paralyzed, given the current chaos and implications of these recent directives and their impact on us and our partners. Um, I've been in the field for 48 years. I lived through the Nixon administration, I lived through the Reagan administration, and notably in the latter, during his first term, President Reagan banned all NIH funding for social and behavioral science research. For 4 years, it was not permitted to fund that research directly through NIH. And people found ways to reframe, to integrate the nature of social behavioral science research into the biomedical research agenda. And it has, with great value and important outcomes. I am confident too. We are very resilient and persistent, and I believe that we will last the day and be able to once again um, be able to work and chart the way forward for how the kinds of topics that we've been discussing and will continue to discuss in this arena can continue to add to the value of the science, but also the benefit of the health of all US citizens.
Thank you so much, Doctor, for those words of inspiration and motivation. I think I remember you giving that example at our recent CEDER meeting and walked away feeling hope, a little bit more hope and optimism. And I do think that there's been a lot of pushback in the scientific community, obviously, but also from the public, and sort of recognizing the importance of medicine and science in public health and um, clinical care and all kinds of outcomes that we care about. So I agree. We can't give up, and we have to keep pushing and finding ways to do the work that we really care about and that motivated us in this journey, in this research journey. Um, Dr. Hipschman, if you could comment on just in terms of the TSBM framework, what actionable steps can you suggest to researchers to apply some of these methods in their own work? I know you shared the model and you talked about, and Dr. Manson, you also mentioned even separate from this model, there's other models and the sort of concepts go across, regardless of which model you're using. But in terms of, translating models like this on the ground in the research that we're doing, what first steps would you recommend?
Yeah, so obviously everything depends on what's your level of budget, access, and time, right? So can you do representation? Can you afford to convene community advisory boards and have hiring people with lived experience to serve as community advisors for your team? Those things are all, what we would hope is a pie in the sky goal. If your budget doesn't allow for that, you're maybe doing things on a shoestring. I'll put in the chat. There's dicemethods.org that was developed by our NIH-funded CTSA here at Colorado as ways to engage with people at different levels of cost and different methods to do for that as well. But I think ideal is being able to have community members with lived experience to be a part of the research team and to be active collaborators with you. And then from there, you sort of go with what you're able to pull together. That's for representation, and I'd like it to be from beginning to end either way of a project. And ideally, partners you continue to work with across multiple projects. That's what we've been able to pull together with our CDTR as we showed our ecosystem, and we have this rich network with CEDER. I know you're doing the same, trying to pull together people who can be part of multiple different projects. Representativeness, it's really being thoughtful to look at different subpopulations, even if you're not powered to do so, compare heterogeneity of effects for a program that you're offering. Is it working for older and younger people? Is it working for different sexes? Is it working for different races? What are the different things? Is there a digital divide? Are there other factors involved? So just being thoughtful for what I'm offering, who might this be working for and who might it not be working for? That can be looked at quantitatively and also qualitatively, understanding how and why this is working for some people and not for others.
Yeah, you just took the words out of my mouth. I was going to say, if you're not always powered to look at impacts on different subpopulations, that the qualitative piece can really help you explore some of those
Absolutely.
impacts, and is really vital actually in terms of gaining some initial data that would hopefully then prompt more adequately powered quantitative studies. So that's great. And I guess I have a question that I'll pose to all of you. Just, the more you bring in different people into research and different voices, you can often have different priorities that come up. And so anybody who wants to chime in here, but can you provide an example you faced in your research of hearing about different priorities from different people or groups and how you work to resolve them?
So we constantly have different priorities and different interests in our work because people come from different viewpoints, right? Most folks that we work with want actionable results. They want something that they can put to work right away. And yet it's our responsibility to explain the importance of desktop research and how it can make a difference in our lives and how it can translate to usefulness. So we're constantly being asked, well, how does this help us? How does this help us? How does this help us? And yet we also have to explain that we all stand on the shoulders of researchers that have gone before us, right? That we all build on the data that came before us, and we can drill down because somebody did this prior to our work. So it's education, it's sharing goals, it's helping people, again, going back to the idea that you just have to give grace to each other and never assume that what people mean. You always have to understand that they are basically first and foremost wanting to look out for their communities. And so I think that just helping folks understand that knowledge requires data. You cannot change what you don't know.
Great. Thank you so much. I'm noticing the clock and we're just about at the end of our time together. I wanted to give Dr. Islam a chance just to close us out.
Well, first of all, I wish I could give everyone a huge virtual hug right now. I think this session was really reaffirming for many of us. And I can't think of a better way for us to kick off our learning exchange series with a session that really elevated the role that researchers and communities like this community this audience are playing in advancing the science of health and health equity. So just a few closing thoughts and next steps. We do have a very brief post-meeting evaluation. Please do take a few moments out of your day to complete it. The QR code is here. You can find the link there. I believe we'll also put a link in the chat and can send it out via email afterwards. I found this session hugely valuable. I know it spurred a lot of different ideas and questions for me. And I hope it did the same for you. But if there are other areas that you hope we can explore in the future, this is the place to get that feedback. So please take a few moments to complete it. We have our next CEDER Learning Exchange planned for April 22nd, and we're co-hosting this in collaboration with our funding partner, NIDDK. And the tentative topic for this session will be best practices and community engagement. Again, similarly, hearing from partners across the country, sharing their case studies on work related to type 2 diabetes. And then finally, our center is only as strong as the clients that come to us. So please do take a look at our website, request consultation and studio services, spread the word to your colleagues and partners, and also join our network. You know, we are also looking to many of you to serve as experts, and there are opportunities to do that with CEDER. So please don't feel free, please, to reach out to us for more information. I'd like to end again with a huge thank you and round of applause to all of our panelists and our facilitator today. We really benefited from your knowledge and expertise. Thank you, everyone, and have a great afternoon.